Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman. I would like to express my deep thanks and gratitude to the organizing committee as well as the board of the Egyptian Society of Chest Diseases and Tuberculosis for giving me the opportunity to share in such a glorious scientific event. Today, I will talk about sleep in the context of interstitial lung disease. And I have no conflict of interest. The interstitial lung diseases are a diverse group of diseases unified by deposition of extracellular matrix within the lung parenchyma with varying degrees of fibrosis and inflammation, resulting in restrictive lung disease, impaired gas exchange, and exercise intolerance. A third of human life is spent in sleep, and this is a restorative state in health. However, physiological changes that naturally occur in sleep may be deleterious in disease. In interstitial lung disease, sleep architecture is disrupted with nocturnal desaturations and increased incidence of obstructive sleep apnea. The result is that patients have poor sleep quality, reduced quality of life associated with fatigue, as well as disease-related anxiety and depression. These patients also have poorer outcomes with worse survival. We as physicians tend to focus on daytime symptoms and disease progression, but we cannot ignore the contribution of sleep and sleep-disordered breathing on the quality of life and survival in interstitial lung patients. Regarding sleep architecture in interstitial lung disease, patients with interstitial lung disease have poor sleep quality with breathlessness, cough, and disruption of the normal sleep architecture, with increase in stage 1 sleep, reduction in rapid eye movement sleep, and slow wave sleep, with an increased frequency of arousal from sleep, increased measures of sleep fragmentation, decreased sleep efficiency, increased incidence of periodic limb movement disorders. Regarding the respiratory pattern, in wakefulness, patients with interstitial lung disease have an increased respiratory rate, and this phenomenon becomes more pronounced with decreasing forced vital capacity. This rapid breathing allows patients to maintain adequate ventilation despite the small tidal volumes and impaired gas exchange, which is caused by stiff fibrotic lungs, and means that patients usually remain eukapnic until late in the disease. Several studies have demonstrated that this increased respiratory rate is also maintained during sleep. And regarding nocturnal oxygenation, in normal REM sleep, relative hypoventilation occurs because of the marked reduction of the tone of the respiratory or skeletal muscles. That means the diaphragm is the only muscle active in ventilation. This may result in a small reduction in oxygen saturations during REM sleep, even in healthy state. Interstitial lung disease patients spend a mean of 34% of sleep time with saturations less than 90% compared with 0.9% in healthy controls. Nocturnal desaturation is predicted by resting daytime oxygenation. These patients are on the steep part of the oxygen hemoglobin dissociation curve, meaning that small changes in arterial oxygen tension cause larger decreases in saturation. Debate remains as to whether the degree of restriction is associated with increased nocturnal desaturation. Consequently, desaturation may be correlated with total lung capacity and DLCO. Regarding sleep disorder breathing, and of course the obstructive sleep apnea is the most famous, obstructive sleep apnea has been recently identified as a potentially important comorbidity in patients with interstitial lung diseases. Physicians may not recognize the true incidence of sleep disorders in interstitial lung disease or consider that the rapidly progressive course of the disease means that it's not relevant. Studies have shown high rates of moderate to severe obstructive sleep apnea, ranging between 51 and 72% in patients with idiopathic pulmonary fibrosis. The mechanism of obstructive sleep apnea in patients with fibrosing interstitial lung diseases remains debatable, One hypothesis is that small lung volumes increase traction on the upper airway and hence increase collapsibility, which is exacerbated in sleep by reduced tone of the intercostal muscles and hence further reduction in the functional residual capacity. How does sleep interact with interstitial lung disease? In fibrosing interstitial lung disease, we have hypoxia. The patient is hypoxic, and this hypoxia leads to increased release of hypoxia-inducible factor 1, leading to fibrosis, and endothelin 1, leading to emergence of pulmonary hypertension. Both fibrosis and pulmonary hypertension leads to worse survival. When these patients of interstitial lung disease go to sleep, we have added disrupted sleep architecture leading to fatigue and reduced quality of life. Keeping in mind, as we said, the high incidence of obstructive sleep apnea in these patients, this leads to increased peripheral traction, which is called the shear stress effect, that adds more to fibrosis and leads to worse survival. Quality of life. Sleep quality remains certainly impacts on quality of life in patients with interstitial lung disease. Nocturnal desaturation, especially the mean nocturnal oxygen saturation, was associated with clinically significant reductions in the physical functioning domain, social functioning domain, and energy and health perception domains of the SF-36 health-related quality of life questionnaire. That means that the nocturnal desaturation affects both the physical health and medical health dimensions of this questionnaire. In idiopathic pulmonary fibrosis patients who had obstructive sleep apnea with nocturnal hypoxemia, they found to have worse health-related quality of life measures as measured by the St. George Respiratory Questionnaire when compared to those without sleep disorder breathing. In patients with idiopathic pulmonary fibrosis, we have an important parameter, which is the maximum difference between SpO2, between wakefulness and sleep. And this parameter was found to predict survival. Another important parameter, which is the minimum oxygen saturation during sleep. Both parameters were found to be correlated to low DELCO, low post 6-minute walk test oxygen saturation, higher Medical Research Council dyspnea score, increased estimated right ventricular systolic pressure, and high apnea-hypopnea index. Pulmonary hypertension is known to be a poor prognostic indicator and may account for some of the excess mortality seen in patients with interstitial lung disease and nocturnal desaturation. Nocturnal desaturations might promote pulmonary hypoxic vasoconstriction and hence the development of pulmonary fibrosis, pulmonary hypertension, either through release of endothelin 1 leading to pulmonary vascular remodeling, or through resetting of the peripheral chemoreceptors and reduction of the hypoxic drive. Role of nocturnal hypoxemia and sleep disorder breathing in disease progression. I mean the progression of the interstitial lung disease. Obstructive sleep apnea with nocturnal hypoxemia was associated with increased risk of disease progression and mortality whenever compared with patients with no obstructive sleep apnea or with obstructive sleep apnea but without prolonged desaturation. And this correlation was independent of FVC or DELCO. It has been suggested that obstructive sleep apnea might promote fibrosis because of the recurrent stretch injury to the peripheral lung because of breathing against closed upper airways. Obstructive sleep apnea might promote the initial development of idiopathic pulmonary fibrosis. This concept came from an analysis of 1,690 asymptomatic patients underwent both high-resolution CT and full-night polysomnography. Patients with moderate to severe obstructive sleep apnea had an increased incidence of both high attenuation areas and interstitial lung abnormalities. Both are potential radiological precursors of interstitial lung disease. The authors also found elevated serum levels of surfactant protein A, which is associated with alveolar injury, and matrix metalloproteinase 7, which is implicated in extracellular matrix remodeling in subjects with moderate to severe obstructive sleep apnea. In the lung, there is evidence that the hypoxic microenvironment is pro-fibrotic, with elevated lactate within fibrotic lung contributing to activation of hypoxia-inducible factor 1 and transformation growth factor beta. There is also a suggestion that abnormal breathing pattern and frequent desaturations associated with sleep disorder breathing may be associated with both hypoxia, reperfusion injury, and peripheral traction stress. Treatment of sleep disorders in patients with interstitial lung disease. First, nocturnal oxygen therapy. Treatment of resting hypoxia with oxygen is a well-established practice in the patient with interstitial lung disease. Correction of exercise desaturation with ambulatory oxygen. Modest questionnaire. This is a self-administered interstitial lung disease specific questionnaire that consists of 3 main domains: psychological, breathlessness and activities, and chest symptoms domain. Treatment of obstructive sleep apnea. Patients with idiopathic pulmonary fibrosis and moderate to severe obstructive sleep apnea diagnosed at polysomnography and who were compliant to CPAP therapy showed significant improvement in all sleep and quality of life questionnaires at 1-year interval, while those with poor compliance showed improvement only in the Pittsburgh Sleep Quality Index and Fatigue Severity Scale. In addition, those who tolerated CPAP had improved survival at 2 years. However, we still lack a well-designed randomized controlled trial investigating the effect of CPAP therapy on idiopathic pulmonary fibrosis-related quality of life. When we apply CPAP treatment in interstitial lung disease, we may be faced with many problems, like that CPAP initiation may result in an exacerbation of the dry irritative cough, leading to non-acceptance of CPAP treatment or poor compliance. VQ abnormalities in association with increased dead space ventilation due to rapid and shallow breathing can result in prolonged desaturation periods despite abolishing of the obstructive respiratory events as the desired effective CPAP pressure. And these patients may require supplementary oxygen through the CPAP circuit. And the unpredictable course of idiopathic pulmonary fibrosis may lead to inadequate CPAP use. These patients may be in need for frequent retitration, or we may use the automatic PAP therapy or auto-PAP from the start. Corticosteroids, which are used frequently in patients with interstitial lung disease, have negative influence on sleep quality and architecture. They also cause central fat deposition, resulting in problems in titration and acceptance of the CPAP therapy. And lastly, depression or other mood disorders may be a reason for CPAP non-acceptance. And this patient, we may use some of the antidepressant medications like the selective serotonin receptor antagonist. And thank you so much for your attendance and attention.
شكرا لحضرتك يا دكتورة إيمان. والمحاضرة الثانية هتبقى عن السليب ديس اوردر ان بريجنانسي. دكتورة إيمان جلال تشرفنا بالحضور، تشرف المؤتمر، أستاذ الأمراض الصدرية في جامعة عين شمس.
Thank you, Mr. Chairman. Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizing committee of the 61st International Conference of the Egyptian Society of Chest Diseases and Tuberculosis. My supreme gratitude goes to Professor Muhammad Awad Tajuddin, Professor Muhammad Siddiqui, and Professor Jihan Al-Assal. The topic of sleep disorders in pregnancy actually is not a new one. It dates earlier, since the time of Hippocrates. But day after day, with the better understanding of the normal physiology of pregnancy, we have come to accept and to realize the factors responsible for the development of new onset sleep disorders, as well as worsening of pre-existing sleep disorders during pregnancy. That it's now not surprising to know that up to 66 to 94% of pregnant females challenged to sleep during pregnancy. The choice of medications during pregnancy is limited among the pregnant population, yet the adverse outcomes of sleep disorders during pregnancy mandates proper management. The agenda of my presentation will discuss the following topics: the alteration of sleep during normal pregnancy, the interrelation between pregnancy and different sleep disorders, namely sleep-related breathing disorders, restless leg syndrome, insomnia, and narcolepsy. Now, what happens to the normal sleep during pregnancy? The pregnant females are under the effect of mechanical as well as hormonal factors. The mechanical factors are represented by the growing gravid uterus, while the hormonal factors are represented by the peaking of the levels of estrogen and progesterone levels during the 3 trimesters of pregnancy. So how do these affect the 3 trimesters of pregnancy? Starting with the first trimester of pregnancy, although the females might sleep longer periods, yet the quality of this sleep is poor because the deep sleep or the delta sleep is reduced. Together with the effect of the progesterone over the muscles of the bladder producing nocturia and increase in the nocturnal core body temperature, all of which will contribute to produce frequent nocturnal awakenings. As a result, there will be excessive daytime sleepiness as well as daytime fatigue. Now, coming to the second trimester of pregnancy. Sleep in the second trimester of pregnancy is better than that of the first trimester. The total sleep quality is improved. The deep sleep is increased in the second trimester. Still, some residual symptoms from the first trimester might be present. Now, coming to the real nightmare, the third trimester of pregnancy. In this trimester of pregnancy, the females face challenges to sleep because all the factors contribute to poor sleep. The overall total sleep time is reduced. The quality of sleep is impaired. There is decrease in the deep sleep or the delta sleep, increase in the light sleep or stage 1 non-REM sleep. And the growing gravid uterus produces pressure over the bladder, producing nocturia, over the stomach, producing GERD, and over the spine, producing back pain, all of which will contribute to impairment of sleep and frequent awakenings after sleep. Now, starting with the first sleep disorder during pregnancy, which is the sleep-related breathing disorders. Do all pregnant females get sleep-related breathing disorders? Although it's a common disorder, not all females get this disorder, because there are some factors that are pro for the occurrence of this disorder, other factors that prevent the females from having this disorder. As we all know that females in the reproductive period are protected from the occurrence of sleep-related breathing disorder when compared to males and to older females. Yet when they become pregnant, there is an increased risk of sleep-related breathing disorder compared to their counterparts, non-pregnant females. So what are the pro factors that predispose to sleep-related breathing disorder? The first of which is the increasing level of the progesterone and the estrogen hormone. These hormones will cause hypersecretion, will cause mucosal edema, and will cause increase in the capillary engorgement. This will lead to narrowing of the oropharynx, the nasopharynx, and the hypopharynx, with increase in the airway resistance, increasing the Mallampati score, and increasing the risk of sleep-related breathing disorder. Pregnancy rhinitis, which is a common phenomenon, predisposes to nasal congestion, and this will in turn increase the overall resistance within the airways and predisposes to sleep-related breathing disorder. The uterus is now growing, it's pushing the diaphragm upward and increasing the anteroposterior diameter of the chest, and this will lead to a reduction in the functional residual capacity by nearly 20 to 25% of normal. And this reduction in the functional residual capacity will lead to early closure of the small airways, VQ mismatch, and impairment of gas exchange, especially in the supine position. Now, what are the protective factors against the occurrence of sleep-related breathing disorder in a pregnant female? First of which, the increasing in the progesterone hormone will lead to increase in the stimulation of the respiratory center and increasing respiratory drive to compensate for the increased oxygen demand by a pregnant female. And this will increase the minute ventilation. Again, the females prefer to sleep on the lateral position rather than the supine position. And as we all know, the supine position has more predilection for the occurrence of respiratory events in sleep-related breathing disorders. And as we said previously, REM sleep is decreased especially during the 3rd trimester of pregnancy, and this stage is known to have pronounced respiratory events in sleep-related breathing disorders. Now, why do we have to care about sleep-related breathing disorders during pregnancy? This is because simply they have adverse outcomes. These adverse outcomes are mostly pronounced over the mother. Maternal adverse outcomes are well reported, where sleep-related breathing disorder predisposes to the development of gestational diabetes mellitus, gestational hypertensive diseases such as hypertension in pregnancy, preeclampsia, and eclampsia. The fetal adverse effects, although less pronounced than the maternal adverse effects, yet it's reported for mothers having gestational diabetes mellitus to have large birth weight infants. Also, the prematurity is common in fetus for mothers with sleep-related breathing disorder. Now, the pregnancy will suffer from cesarean section increased prevalence, the prematurity and the preterm birth, and the liability for miscarriage. How do we manage sleep-related breathing disorders during pregnancy? The first step is diagnosis, and diagnosis here is challenging. It's because the symptoms suggestive of sleep-related breathing disorders overlap with those related with the normal symptoms encountered during pregnancy, the tiredness, the fatigue, and the excessive daytime sleepiness. Yet, high clinical point of suspicion when suspecting habitual snoring, new onset snoring, or the presence of comorbidities with pregnancy and increased body mass index, all of which can tend for the physician to use screening questionnaires as a screening tool for sleep-related breathing disorder. The Stop Bang questionnaire is a good tool to use this. Also, the Berlin questionnaire can be used with good results. Yet, the gold standard for diagnosis will be the overnight polysomnography. Coming to the management of this disorder, the first line of therapy is the PAP therapy. It's the most convenient, most accepted line of treatment for such females. And since most of the sleep apnea are obstructive, then the choice will be between the APAP and the CPAP. Yet, due to the changing in the body position and the physiology during pregnancy, APAP will be appropriate more than the CPAP due to the ability to change automatically the pressure along the whole course of pregnancy. Do these females encounter central sleep apneas? Sometimes they encounter central sleep apneas, although rare, because the instability of the sleep center and the hyperventilation produces a reduction in the partial pressure of carbon dioxide, and this leads to apnea. In this case, if there is central sleep apnea, then the management will be by adaptive servoventilation rather than the APAP or the CPAP. Oral appliances are not efficient in pregnant females because they need multiple fitting sessions. Besides, they need refitting along the whole course of pregnancy with increasing maternal body weight. Definitely, surgery is not appropriate because of the adverse outcomes during pregnancy. And the lifestyle modification can be applied by the positional therapy, especially if the female is encountering positional obstructive sleep apnea without desaturation, wearing a tennis ball t-shirt to prevent the sleeping on the supine position. Weight reduction is not suitable, definitely, in a pregnant female. And there are some considerations during labor where the labor is preferred to be under regional anesthesia rather than general anesthesia. Avoid using opioids as much as possible during labor and to apply PAP therapy during the labor of the pregnant female. Coming to the next sleep disorder, which is restless leg syndrome. The irresistible desire to move the limbs during sleep has a female predominance of 2 to 1 in the general population. This increased prevalence among females because there is a peaking of 2 to 3-fold during the 3rd trimester of pregnancy in females. That it's not astonishing to know that 36% of pregnant women in the 3rd trimester encountered gestational restless leg syndrome. Now, coming to the diagnosis of this disorder. This is accomplished by detailed history taking the symptoms suggestive of restless leg syndrome, the irresistible desire to move the limb accompanied by pain, aggravated during night and aggravated after prolonged periods of sedentary life. We can use some questionnaires to apply or to assess the severity of this restless leg syndrome during pregnancy, and the most famous of which is the International Restless Leg Syndrome Study Group questionnaire, which identifies that the severity is moderate to severe in pregnant females. That mandates treatment. Do we need PSG to perform an overnight polysomnography in this patient? Actually, detailed history is enough, and there is no common need for polysomnography. Again, why do we have to treat? We have to treat because complications are common in the form of preterm birth, where there is a 2 to 3 increased folds of preterm birth for pregnant females having restless leg syndrome in absence of any other obvious cause. Again, the pregnancy-induced hypertension is common complication of restless leg syndrome during pregnancy. Unfortunately, most of the pharmacological treatment are not suitable for a pregnant female, either because insufficient data or they cross the placenta and produce teratogenic effect. Yet, because iron deficiency is one of the main pathogenesis of sleep-related breathing of the restless leg syndrome during pregnancy, so if this female is having a ferritin level less than 75 milligram per liter, then iron supplementation, either oral or IV during pregnancy, can be used. The non-pharmacological treatment, namely the massage and the stretching, can be used. Yet, if there is no response with the non-pharmacological treatment, low dose of some medications can be used cautiously, such as the pramipixole. Females during the 3rd trimester of pregnancy report that the ability to initiate or maintain sleep is a luxury that they cannot afford. That's because insomnia is common during pregnancy. Several factors along the 3rd trimester of pregnancy contribute to this increased prevalence of insomnia. As we have said previously, the insomnia can be predisposed by the GERD, the nocturia, and by the back pain, the fetal kicks. Also, the progesterone has same binding site for cortisol, and this increases the free cortisol, which is an awakening hormone or causes arousal. Before delivery, the peaking of oxytocin, which is a delivery hormone, this will lead to the awakening of the patient because this is a waking hormone. Now, how do we manage insomnia during pregnancy? The first step is the diagnosis, and the diagnosis is made by sleep diary, knowing the pattern of sleep of the patient, the time of going to bed, the time of waking up, and the pattern of going to sleep, and the polysomnography here has no role. We just rely upon the sleep diary. We treat insomnia because of the consequences manifested by depression, the development of gestational diabetes mellitus, preterm birth, and hypertensive disorders during pregnancy. But again, the pharmacological therapy is mostly not appropriate class C, D, or X during pregnancy, except for 2 drugs, which are the antihistaminic diphenhydramine and the zolpidem, which can be used safely during pregnancy without reported side effects. The non-pharmacological treatment implies sleep hygiene with a regular sleep-wake cycle, using a stimulus control, going to bed whenever indicated, and leaving bed whenever awake, to use the cognitive behavioral therapy directing the unbelievable thoughts or the wrong thoughts for insomnia, limit the fluid intake before sleep to decrease nocturia, and applying exercise, meditations, and relaxation. The last sleep disorder is the narcolepsy, a rare sleep disorder. Unfortunately, this disorder peaks during late adolescence and early pregnancy before the time of the pregnancy, mostly in most cases. So females are usually diagnosed before this time. Narcolepsy is diagnosed by polysomnography followed by multiple sleep latency tests, although we might use the cerebrospinal fluid hypocretin level to diagnose such disorder. Unfortunately, all the medications of narcolepsy, stimulants, and anticatapletic medications are unsuitable during pregnancy, and the treatment should be individualized based on the symptoms of the patient. The outcomes of labor, the outcomes of narcolepsy on labor mandates that C-section is preferable to avoid cataplexy. Regional anesthesia is preferred than general anesthesia. Pain control is mandatory because it initiates cataplexy or trigger cataplexy, and to avoid any triggers such as infection that provokes cataplexy. And finally, it's our mission to provide an enjoyable sleep for every pregnant female. Thank you.
شكرا دكتورة إيمان على المحاضرة الرائعة. ولو الدكتور محمد زيدان، حضرتك موجودة يا دكتور؟ الدكتورة لوس سليمان نتشرف بان احنا نسمع المحاضرة عن how to deal with complicated obstructive sleep apnea. الدكتورة لوسي أستاذ في جامعة المنصور.
السلام عليكم. First of all, I want to thank all the organizing committee of this conference for the Egyptian Society of Chest Diseases and Tuberculosis, and for this invitation for me for this to present this lecture, and I want to be very simple lecture for you. Complicated obstructive sleep apnea. This lecture, I want to illustrate that the obstructive sleep apnea is not only a problem of respiratory disorder, it's a multidisciplinary and multiple problems associated with this respiratory problem. We deal with it. And actually, we have many problems maybe hidden to some physician when deal with obstructive sleep apnea patient. My agenda today, we have two arms for this lecture. The first one is a decision-making problem. We deal with patient with obstructive sleep apnea. A polysomnography report and cardiovascular related problem in obstructive sleep apnea diagnosis. And also we have treatment emergent problem like even during titration or subjective problem after we start the treatment, and also objective problems. This is an obstructive sleep apnea, and this is the all systemic complication associated with this problem, starting from the cardiovascular, depression, increased insulin resistance, and even hormonal disturbances, stroke, and maybe death. The first one is a decision-making problem. Is it obstructive sleep apnea is only depend upon apnea-hypopnea index? Actually, no. Obstructive sleep apnea, when we look for the polysomnographic report, is a very long report and all should be analyzed well and should be also interpreted well because we have many complications may be hidden for some sleep physician. The first one, we should to check for the sleep stages, whether it's normal or not normal. If the patient has a normal percentage for each sleep stage or no. The patient if has normal sleep efficiency or abnormal sleep efficiency. If we have adequate time for the sleep recorded time and the total time of sleep to be a reliable study or no. And also we should to check for the sleep onset latency and also REM latency. The second one, which is the most important for the chest physician especially, is apnea-hypopnea index and what's called respiratory disturbance index. And the difference actually between respiratory disturbance index and apnea-hypopnea index is what's called RERAs. And we should to submit also RERA associated with apnea-hypopnea index to reach to the respiratory disturbance index. And also we should to check for either obstructive or central. The second one is the oxygen saturation. We should to check for the basal oxygen saturation and minimum oxygen saturation and also oxygen desaturation index. And also saturation less than 90% of night, which is very important to detect if your patient needs oxygen therapy or not. The first problem also we deal with patient in obstructive sleep apnea, and one of the most important problem is a cardiovascular problem. The first one is a nocturnal hypertension. Firstly, you should to know what is the normal circadian rhythm for the blood pressure during over the day and night. Normally, the blood pressure is increasing gradually until reach to the maximum at the mid-morning and about 10 a.m. and then decreasing slowly to reach to the most sleep dipping and 3 a.m. So normally the most decreasing blood pressure all over the day is at 3 a.m. We should to know what is the abnormal blood pressure circadian pattern we should face in patient with obstructive sleep apnea or any patient. Maybe you should to know what is the meaning for sleep dipping, extreme dipping, non-dipping, and reverse dipping or riser. What do you mean by nocturnal hypertension? Firstly, nocturnal hypertension means that the blood pressure is increased more than 120 over 70 millimeter mercury at night. Normally, we have a patient is sleep dipping. Dipping, it means that blood pressure decreasing by 10 to 20% during sleep. And also we have extreme dipping, which means that in blood pressure decrease more than 20%. Non-dipping decrease but less than 10%, and the reverse dipping increase in blood pressure during night, which showed in patient with obstructive sleep apnea. How can we evaluate the blood pressure by polysomnography, which is very important? By polysomnography, by technique, what's called pulse transit time, and also 24 hours blood pressure assessment. Pulse transit time is a very special technique, and they need time to be illustrated for you, but it's actual to measure the blood pressure during sleep by polysomnography and detect if the patient has nocturnal hypertension or not. This is the part for the maximum systolic pressure and also diastolic pressure during sleep. If the patient has nocturnal hypertension, we have two strategies of treatment. Either we give the patient 24-hour antihypertensive treatment to initiate the standard treatment to cover all over the day and the night, or you start chronotherapy, add-on therapy during only the night with patient with nocturnal hypertension. The second cardiovascular problem also we meet in patients with obstructive sleep apnea, and we deal with it when we interpret the sleep report, and sometimes we not, maybe not important for some physician, but actually is very important and very common in patients with obstructive sleep apnea. Also, the normal circadian rhythm of heart rate during sleep, the patient has normally parasympathetic activity, so decreasing in sleep circadian rhythm. And decreasing in heart rate, and there is no increasing in heart rate. When we face my patient and we discover that the patient has arrhythmia during sleep, so the patient has a problem. Actually, all types of arrhythmia can be shown in patient with obstructive sleep apnea, from sinus tachycardia, atrial fibrillation, atrioventricular block, ventricular problem, and even heart block, and even sudden cardiac death may be present in patients with obstructive sleep apnea. So it's very important problem we should to face in our patients. Simply the hypothesis for the arrhythmia. The first one is presence of hypoxemia, which may lead to stimulate the sympathetic activity and leads to the patient development of the arrhythmias, or maybe coexisting hypertension, or either in increasing negative intrathoracic pressure, which stimulate channel ions in the heart and leading to arrhythmia. However, the hypothesis, but we have actually a problem of arrhythmia. But it's completely different from the treatment of hypertension, because any cardiologist, you ask him for treatment of arrhythmia in patient with obstructive sleep apnea, ask you to correct the primary problem. If you correct obstructive sleep apnea and correct hypoxemia, all arrhythmias will be improved and the patient becomes normal. If the patient take continuous positive airway pressure therapy and the patient has correct the problem of obstructive sleep apnea, either surgical or by CPAP therapy or by BAP therapy, the patient will not be need for antiarrhythmic treatment. The third one is a heart failure. Heart failure actually is present in both types, of most common types of sleep apnea, either obstructive sleep apnea or central sleep apnea. And also this is a Chine-Stokes breathing, which is a one pattern which is present in patient with heart failure, which is characterized by 3 consecutive cycles of crescendo-decrescendo breathing. For this pattern of breathing, crescendo-decrescendo, associated with central apneas and hypopneas, provided that the cycle is more than 14 seconds. The cycle from the start of the Chine-Stokes breathing to the second start, or the first start of the central apnea to the first start of the second central apnea, should be at least 14 seconds, and at least the study containing 5 central apneas during the study of the sleep study at least. How can we treat this heart failure? We should to do both treatment of obstructive sleep apnea and also cardiac therapy. But firstly, you should to optimize patient according to the treatment of medical management like ACE inhibitor, beta blocker, and diuretics, cardiac resynchronization, left ventricular assist device to optimize the treatment of heart failure firstly, and then also treatment of the patient according to either reduce the ejection fraction or preserved ejection fraction. If the patient can obstructive sleep apnea, you should to start CPAP therapy to improve cardiac function, blood pressure, and also exercise capacity and the quality of life. For the patient with predominant central apnea, you should also start by CPAP firstly, but with low pressure, to not aggravate the patient by severe hypocapnia. If not patient responding, you can start adaptive servoventilation, but you should to know that adaptive servoventilation cannot be used in patient with ejection fraction less than 45%. So it's preferable to use BiPAP ST more than adaptive servoventilation. The second arm, which is the treatment-related problems. From the titration, if you have a manual titration lab in your sleep units, when we do the sleep titration, when we do CPAP titration, we found the problem, which is very common, but sometimes we cannot give it any importance, which is epiglottic collapse. Actually, patient with epiglottic collapse, when we start CPAP, the patient cannot offer the CPAP even 1 hour. And sometimes we say that the patient may be improved, maybe not compliant, maybe claustrophobic, but actually the patient has actual problem. Epiglottic collapse means laxity of the epiglottis, which is present in about 12% of adult patients. When we start the titration, we found the patient cannot improve during the titration study. So the patient, when we assist with our colleagues in ENT department, the use of the drug-induced sleep endoscopy has led to better understanding of this complex. And actually, the patient, when do epiglottectomy or diathermy epiglottectomy, the patient will be improved totally. And the patient actually is complaining from actual problem and so not only claustrophobic from CPAP. This is the picture for the laxity of the patient with normal opening is quiet, breathing through the floppy opening is very noisy, and the patient cannot afford CPAP. Treatment of emergent problem even during the follow-up session. In the follow-up sleep study, in the follow-up sleep clinic, either the patient has subjective evaluation and also objective evaluation. The subjective evaluation of our patient as regard the most common problem we meet it is a residual daytime sleepiness after use of CPAP therapy. And actually the residual daytime sleepiness is very common problem in about 6 to 14% of patients. And also we should to understand if this problem is related to the patient is sleepy due to inadequate treatment of obstructive sleep apnea, or patient is sleepy due to obstructive, not due to obstructive sleep apnea. So what is the causes of sleepiness occur in patient treated after CPAP therapy? Due to CPAP, due to inadequate pressure, or the patient has persistent leak, or the patient has inadequate mask. So this is a subjective problem. How can we detect the patient by objective by me? We should to check for the card reader of CPAP and download for this reader. And you should to check for the very important finding with the residual apnea hypopnea index, if normal or not, the median leak liter per minute within normal or not, and the leak should be less than 24 liter per minute or 0.6 liter per second. And average daily use which should be more than 4 hours per day for at least 5 days all over the day. And if there is persistent central apnea or not, we should to check for this problem. If you find any problem that the mean is inadequately treated by CPAP therapy, if the card reader is normal like this example, mean the patient has sleepy not due to inadequate treatment of obstructive sleep apnea. Maybe due to obesity hyperventilation, maybe due to narcolepsy, maybe due to depression, maybe due to hypothyroidism, narcolepsy, idiopathic hypersomnia. You should to evaluate all these causes because it may lead to residual sleepiness. The last objective follow-up session, the follow-up problem, we found it during follow-up session in a sleep clinic, is a complex sleep apnea. Complex sleep apnea means the patient has a central apnea, either persistent after CPAP therapy of treatment of obstructive sleep apnea or emergent after treatment of obstructive sleep apnea. And I need 2 minutes only. And actually, the patient of complex sleep apnea is a patient of obstructive sleep apnea treated by CPAP, and the patient is still complaining that he is not normal, that he is not well. The patient is not improved totally. When we check for the card reader for the CPAP, we found the presence of central sleep apnea. This central sleep apnea may be done due to the patient develop hypocapnia, due to either relief of the upper airway obstruction more than we need and increase CO2 removal and leads to drop of the CO2 and develop central apnea, or over titration leads to stimulation of the lung stretch receptor and leads to central apnea, or the patient has an unstable sleep state, increased arousal, and leads to drop of the CO2, which leads to central apnea. So the complex sleep apnea is very important to be evaluated during follow-up session in a sleep clinic. How can we treat it? Either decreasing the CPAP pressure. If the patient improve, that's okay. If the patient not improve, we can shift to the BiPAP therapy or adaptive self-ventilation. Sometimes we need alternative therapies in addition to the device, like Diamox, Eufillin, and sleep aids. And thank you for all.